Good afternoon. I'm Captain John Iskander. Welcome to the November session of Public Health Grand Rounds. Next month, we will have 2 Grand Round sessions, including a special session in 2 weeks on advanced molecular detection of infectious diseases. Please join us then. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and others. For more information, please consult the Grand Rounds website. Grand Rounds is also available on Facebook, Twitter, and YouTube. We have a new featured video segment called Beyond the Data, which is posted to our website and to YouTube shortly after the session. So our regular audience is used to Dr. Popovich's comparisons of our speakers with movie stars. For this month, we have speakers, most of them, who have starred on TV or on the web. Laurie Hicks, as seen on WebMD. Arjun Srinivasan, as seen on Frontline. Dr. Sherry Ling, I'm not sure exactly what this is, but she looks pretty good, pretty fashionable, I would say, on that. And then there's Dr. Finkelstein. This is what he told me when I asked him for a video clip. So, as you'll hear more about shortly, Grand Rounds is pleased to be part of Get Smart About Antibiotics Week. Look for more information in CDC Science Clips, the current issue of MMWR, at cdc.gov/getsmart, and pretty much everywhere, even on my coffee mug. Immediately following our 4 speakers, we will have concluding remarks by our director, Dr. Frieden, followed by a Q&A session. It's my pleasure to introduce Dr. Laurie Hicks.
Thank you, John. Good afternoon. I am Laurie Hicks, Medical Director of CDC's Get Smart Know and Antibiotics Work program. I'm here today to discuss the benefits and unintended consequences of antibiotic use and discuss antibiotic use and antibiotic prescribing practices in the community. The life-saving benefits of antibiotic use in medicine and public health are undeniable. Infectious diseases that were once deadly are now treatable, substantially reducing deaths compared to the pre-antibiotic era. We should also recognize that antibiotics are an important and crucial adjunct to modern medical advances, permitting surgical and medical treatment for a variety of serious illnesses. Alarmingly, we are facing the end of the antibiotic era. No new antibiotic classes have been developed in over 10 years, and the frequency of antibiotic-resistant infections is increasing. More toxic and dangerous antibiotics are being pulled off the shelf to treat common infections. In some instances, there are simply no options for treatment, and that is why we must treat antibiotics as a precious resource to only be used when absolutely necessary. Before we dig into some of the details about prescribing for adults and children, we should recognize that there are standards that guide what constitutes appropriate prescribing. There is broad consensus in the form of practice guidelines from multiple professional societies and CDC which support more targeted antibiotic prescribing. In particular, conditions for which antibiotics are not routinely indicated are viral infections, including colds and bronchitis. Research has also helped us clarify that some types of infections, such as ear infection or otitis media, for which antibiotic treatment had formerly been routine, can in many instances be managed with watchful waiting. Whenever possible, diagnostic testing, such as the rapid strep test, should be used to differentiate bacterial from viral infections to guide prescribing. And when an antibiotic is indicated, it's critical to choose the recommended antibiotic, dose, and duration to treat the infection. There are unintended consequences of antibiotic use. Antibiotic-associated adverse events range from minor conditions such as rash to much more severe, such as systemic allergic reaction, including anaphylaxis. Antibiotics are responsible for almost 1 out of every 5 visits to emergency departments for drug-related adverse events. And this is especially problematic for the pediatric population, as antibiotics are the most common cause of drug-related emergency department visits for children. There is some recent fascinating but preliminary information suggesting a potential link between antibiotic use and obesity and chronic disease. One published study found that exposure to antibiotics during the first 6 months of life was associated with elevated body mass index, or BMI, later in childhood. Further studies are needed to understand whether there are long-term implications for BMI and cardiovascular disease risk and other chronic diseases. Clostridium difficile diarrhea is a type of adverse event that occurs as a result of disruption of normal gut bacteria due to antibiotic use. Like other serious complications of antibiotic use, it causes significant morbidity and mortality. 250,000 infections and 14,000 deaths each year in the US, leading to an estimated $1 billion in medical costs. Perhaps the most important unintended consequence of antibiotic use is antibiotic resistance. Let's quickly review how antibiotic resistance happens. Under normal circumstances, our bodies are populated with millions of bacteria, and a few are drug resistant. When we take antibiotics, the bacteria causing the illness is killed, leaving the bacteria that are resistant. Now the drug-resistant bacteria that are left can grow and take over. Finally, some bacteria can genetically transfer their drug resistance information to other bacteria, magnifying the problem. Antibiotic resistance is an increasingly common problem, causing an estimated 2 million illnesses and 23,000 deaths each year. Antibiotic-resistant infections add considerable and avoidable costs to the already overburdened U.S. healthcare system. The total economic cost of antibiotic resistance to the U.S. economy has been difficult to calculate. The current estimate is $30 billion annually in excess direct healthcare costs. When additional costs to society for lost productivity are added, the total cost might be as high as $35 billion per year. As that multi-billion-dollar figure indicates, the direct cost of antibiotic resistance and antibiotic-resistant infections that we all pay goes well beyond just the cost of another antibiotic. Resistant infections require prolonged and costlier treatments, extend hospital stays, and necessitate additional provider visits and healthcare use. And most importantly, they result in greater disability and death compared to infections that are easily treatable with antibiotics. To help understand how we got here and where improvement is needed, we need to look at what we know about antibiotic prescribing in the US, the who, what, when, and where. In 2009, antibiotic prescription costs totaled $10.7 billion, $6.5 billion, or 62% of the costs as a result of antibiotic prescribing in the community, followed by $3.6 billion in hospitals and $527 million in nursing homes and long-term care. Now, let's take a closer look at community prescribing practices. Providers, including physicians, physician assistants, and nurse practitioners, prescribed 833 prescriptions per 1,000 persons, on average more than 4 prescriptions for every 5 persons in 2010. Prescribing rates by age group were highest for persons less than 10 and greater than or equal to 65 years of age, averaging more than 1 prescription per person per year. We wanted to understand how antibiotic prescribing varies by region, so we looked at antibiotic prescriptions per 1,000 persons of all ages by state in 2010. We learned that state prescribing rates vary markedly and that some states had more than double the prescribing rates of others. For example, there were 1,237 prescriptions per 1,000 persons in West Virginia, compared to 529 prescriptions per 1,000 persons in Alaska. A recent analysis of provider prescribing practices for adults in the community found that acute respiratory infection is the most common reason an adult receives an antibiotic, and more than 1 out of 4 outpatient prescriptions are for conditions for which antibiotics are not needed. Even when antibiotics were indicated, the wrong drug was frequently prescribed. Geographic variation in prescribing was apparent. Providers based in the South were more likely to prescribe for conditions that do not warrant antibiotic use. Provider prescribing practices for children reveal some good news. Pediatric antibiotic prescribing has declined by 1/4 over the past decade. But the bad news is that more than half of antibiotic prescriptions are for respiratory infections, like common cold and bronchitis, which don't warrant antibiotic treatment. In an effort to improve antibiotic use in the community and reduce unintended consequences of antibiotic use, including antibiotic resistance, CDC launched the National Campaign for Appropriate Antibiotic Use in the Community in 1995. And this was subsequently renamed Get Smart, Know When Antibiotics Work in 2003. The program works closely with a variety of partners to reduce unnecessary antibiotic use in the community, and the campaign focuses on increasing awareness about antibiotic resistance and the importance of appropriate antibiotic use among healthcare providers and the general public. Our annual observance, Get Smart About Antibiotics Week, is this week. The observance is intended to increase awareness of antibiotic resistance and the importance of appropriate use of antibiotics in both inpatient and outpatient settings. Using communications and with our partners, we work to engage the media to disseminate messages using both traditional and social media. We partner with a variety of organizations, including public health agencies in 3 continents and more than 40 countries, all hosting observances this week. Efforts to improve antibiotic use in the community also involve establishing national healthy people goals for prescribing. We are beginning to see some benefits from educational campaigns like Get Smart, but further improvement is needed. While the rate of antibiotic prescribing for pediatric ear infections is decreasing on target to reach the Healthy People 2020 goal, antibiotic prescribing for common cold remains just under 30%. We should remind ourselves that in an ideal world, this number should be 0. Separate from the Healthy People goals, CDC plans to establish a national goal for reduction in outpatient antibiotic use for all ages, because what gets measured gets done. In summary, while antibiotics retain their status as essential medical tools, antibiotic-resistant infections are one of the most serious consequences of excessive antibiotic use and constitute an important public health problem requiring an urgent public health response. While studies in outpatient settings show some progress is being made in curbing inappropriate prescribing, our work has just begun. Improvement is needed. Continued monitoring of antibiotic prescribing patterns to identify where interventions are needed, and ongoing multifaceted educational efforts are crucial components of the response. I would now like to introduce Dr. Jonathan Finkelstein.
Thank you. It's wonderful to be here both as a pediatrician and a researcher in this area to talk with you briefly both about some of the progress we've made in the last decade and some possible next steps in promoting judicious antibiotic use in the community. First, let's step back and just think about the goal we're trying to reach. None of us is trying to eliminate antibiotic use. Rather, we seek to eliminate their use in situations when there's absolutely no benefit to the patient. For example, for viral colds and coughs, including what's often referred to as bronchitis. In other cases where antibiotics may be of value, we want to balance the individual benefits that are often relatively small against both individual and population risks. Benefits might include faster resolution of an illness, as for ear infections, and we balance that against risks of allergic reactions, side effects, development of antibiotic-associated infections, and others. In addition, we need to consider the risks to the population overall of the development of resistant organisms. And finally, we need to find new ways to include patients in informed decisions about antibiotic use. We've known for years that patient expectations and preferences affect medical care. In one study in pediatric offices in 2001, more than 2 out of 3 parents of children with respiratory tract illnesses believed antibiotics were needed for their child. It's not surprising that physicians in those offices were 21% more likely to prescribe an antibiotic when they perceived parents wanted one, and 32% more likely to prescribe one for a viral illness for which treatment was frankly unnecessary. More recently, we did some focus groups with parents in Massachusetts, and what was striking, a decade after many of those studies, was the diversity of views we heard. We spoke with 31 parents from diverse social and educational backgrounds in both urban and suburban settings. We heard a number of comments here on the left that suggested that parents would want antibiotics even in cases where we might not think they're needed. One said, "When your kids are screaming and you're getting fevers, I wouldn't be comfortable for my doctors to tell me, let it play its course. I think I'd flip." But in contrast, we simultaneously heard the comments on the right about the consequences and even the fears of antibiotic overuse. We also see signs of progress in surveys we did of parents in 2000 and again in 2013. For example, we asked if antibiotics were needed for colds and flu, green nasal discharge, and deep cough or bronchitis. This chart shows the percent answering never or almost never, the correct answer for all of these. So on the left, you'll see that most parents understand that colds and flu do not respond to antibiotics. Knowledge on this hasn't really increased over the past dozen years. However, if you look in the middle, there is improved knowledge about green nasal discharge and the fact that that does not require antibiotic treatment. Bronchitis is on the right, and we see that knowledge that bronchitis does not require antibiotics is still quite low, though we're making some small progress. So whatever we do to promote judicious prescribing has to address patient perspectives on the left and clinician perspectives on the right. Patients want their symptoms resolved quickly. They value clear explanations, and they still harbor some misconceptions about when antibiotics are useful. But now we're also seeing increasing concern among patients and parents with overuse and resistance. Clinicians, on the right, respond in part to perceived patient expectations. That won't change. Diagnostic uncertainty for some conditions may contribute to overprescribing, and many still think it's quicker to write a prescription than to convince a patient they don't need one. But clinicians, too, are very concerned with overuse and resistance as they see the consequences in their patients firsthand. The fact that these views are increasingly shared by both patients and those who provide health care is real reason for hope. So let me move now to an example in which we've really made great progress. Overall, there's been a 25 to 30% decrease in antibiotic use for young children in the past decade. This has been largely driven by a decrease in prescriptions for middle ear infections, also called otitis media. What's interesting is that once a child is diagnosed with an ear infection, the likelihood that they will be prescribed an antibiotic has remained quite stable. So then, how has there been a decrease in prescribing for otitis overall? The answer is that we clinicians have just stopped making the diagnosis so frequently. Well, how did that happen? How did otitis media go away? Well, professional guidelines certainly have helped by narrowing diagnostic criteria for conditions such as ear infections. And there's been some contribution of the introduction of pneumococcal conjugate vaccine that was recommended for use in all children in 2000. But mostly, clinicians have just changed their threshold for making this diagnosis, largely because of concerns for antibiotic overuse. Decreasing prescribing for bronchitis in adults has been less successful. While most healthy adults recover from bronchitis without antibiotics, it remains the leading reason for prescribing for adults in community settings. Interventions to decrease prescribing have included patient education in clinical settings and clinical decision support. While many of these have had some effect in the range of a 10% decrease in prescribing, treatment rates remain quite high. I think what we've learned is that changing deeply held beliefs about this condition will be gradual. Getting patients to believe that the medicine they have taken all these years was not doing much good will take time, and getting clinicians to change their prescribing will occur gradually as well. So how do we change these patient expectations? Public health messages distributed through many channels can help. Education through physician offices can be particularly potent given the trust that's already established as a source for medical information. There may be a role for distribution of messages in pharmacies, child care centers, and even workplaces, all of which have an interest in decreasing the unnecessary use of antibiotics. There have been a number of local and statewide interventions across the U.S. that have decreased prescribing to varying degrees. In Massachusetts, we did one early in the decade and found that even in the control communities, antibiotic use was decreasing rapidly, up to 20% over the 3 years, likely as because of attention in the lay press and professional press. Our multi-channel effort added a little bit more to that downward trend, with a 4 to 7% decrease seen in toddlers and preschool children. On the provider side, there have been a range of strategies used to try to decrease unnecessary prescribing, all of which have demonstrated some impact, but clearly some are more potent than others. Just distributing print materials to prescribers has only weak effects. Feedback of current practice to clinicians is better, so they can compare themselves to peers and to goals for appropriate prescribing. Academic detailing and opinion leader education are strategies used by pharmaceutical companies, and they've been successful as well in this area. So, are our computers the answer? Electronic decision support, demonstrated here by the image of a bulging eardrum with an infection, has some promise, but we are still really in the early stages of understanding how it can be helpful in this context. A very recent study in Europe showed success in decreasing antibiotic prescribing through web-based training in both use of diagnostic tools and advanced communication strategies for patients with respiratory tract infections. So while each of these strategies has had some impact, what we've learned is that combining several interventions concurrently or combining prescriber interventions with patient education have been most successful. We've also learned whatever strategy is used, it will be most effective if tailored to the specific setting, condition, and attitudes of the target audience. So in summary, we've made substantial progress in reducing unnecessary antibiotic prescribing for some conditions and in some age groups. However, as Dr. Hicks noted, a very high fraction of prescribing continues to be for low-risk respiratory conditions for which symptomatic treatment might be more appropriate. So it is even more urgent that we take action that will move us to the next level of judicious antibiotic prescribing. Development of guidelines by CDC and professional societies is a good first step, but don't expect them to passively diffuse into practice. Widespread adoption will require active implementation using a menu of approaches. And newer methods of quality improvement and implementation science can help us accelerate the spread and design locally tailored interventions to complement broader public health efforts. As we increasingly make health systems accountable for care for large populations they serve, we have the opportunity to develop new quality measures, both for specific conditions and also for antibiotic prescribing rates overall. Once we have those, we can compare rates between individual prescribers and practices. This will allow us to benchmark performance across systems and learn from those who are keeping antibiotic use rates low and achieving optimal health outcomes. Finally, we have to keep working to align patient expectations with the goals of judicious antibiotic use. It's promising that patients hold general beliefs consistent with prudent use of these drugs, but they simultaneously retain some misconceptions. To make continued progress, we have to reinvigorate the partnership in this area between public health and clinicians on the front line. In the end, our patients learn what we teach them one by one. At the same time, we need to see continuing education of the public as a whole as a longer-term investment, but one that is absolutely necessary for success in decreasing unnecessary antibiotic use. Thank you. Our next speaker is Arjun Srinivasan.
Thank you. I'd now like to shift our focus from talking about antibiotic use in outpatient healthcare settings to talking about antibiotic use in inpatient settings like hospitals and nursing homes. CDC's Get Smart for Healthcare campaign is focused on helping improve the use of antibiotics in inpatient healthcare settings. We know that antibiotics are used frequently in hospitals. In 2011, in a single-day point prevalence survey of 200 hospitals in the CDC's Emerging Infections Program, we found that fully half of all of the patients hospitalized on the day of the survey were receiving antibiotics. This percentage is very consistent with many other studies. As you've heard from Dr. Hicks, antibiotic overuse has consequences. These consequences can be even more serious in hospital settings where patients tend to be very sick and are confined to that space. It's been recognized for many decades that antibiotic use in hospitals is frequent and often inappropriate. It's been estimated that up to 50% of antibiotic use in hospital settings is either inappropriate or suboptimal. The authors of this study examined the common causes for inappropriate or suboptimal antibiotic therapy and found that they tended to fall into three major categories. Antibiotics were given for longer than they were needed. They were given to treat infections that would not respond to antibiotics, or they were given in response to culture results that did not represent infections. The good news is that there are impressive benefits that can come from improving the way we use antibiotics in hospitals. One of these is one that Dr. Hicks described. One of the most serious adverse events from antibiotic use is the development of Clostridium difficile-associated diarrhea. This is even a bigger problem in hospitals, where C. difficile can easily be spread between patients on equipment or the hands of healthcare workers. When patients who are exposed to Clostridium difficile also get antibiotics that kill their normal gut bacteria, the risk of C. difficile-associated diarrhea increases dramatically. Given that antibiotic exposure is such an important risk for getting C. difficile, it stands to reason that improving antibiotic use can reduce Clostridium difficile, and this has indeed been demonstrated in several studies. The data here are from one of the largest and most recent of these studies. In response to a national epidemic of Clostridium difficile, clinicians in England have made a concerted effort to improve the use of two types of antibiotics commonly associated with C. difficile. The teal and purple lines on this graph show substantial reductions they have achieved in the use of these two antibiotics through education and improvement efforts. The light blue line shows the dramatic impact these improvements have had on C. difficile in patients older than 65 who are at very high risk for severe complications of C. difficile. In the past 7 years, improvements in antibiotic use in England have led to a nearly 70% reduction in C. difficile in older patients. This represents thousands of patients who did not get infected and likely many lives saved. We know that resistance to antibiotics will develop even if we use antibiotics perfectly. But studies have also shown that overusing antibiotics speeds the development of resistance. But can improvements in antibiotic use actually reverse antibiotic resistance? There are a number of studies that suggest the answer to this question is yes. Here we see the results of one such study, where investigators looked at the impact of a new policy that restricted the use of several key antibiotics at one hospital. They found that resistance in one key gram-negative bacteria, Pseudomonas aeruginosa, actually went down significantly as antibiotic use declined following antibiotic use restrictions. Improving the use of antibiotics can also improve the treatment of often complex infections seen in hospitalized patients. This data is from a study looking at infection cure rates and treatment failure rates following the creation of a hospital program designed to help improve the use of antibiotics. With input from this program, clinicians were significantly more likely to give patients the right antibiotic, resulting in twice as many patients getting cured of their infections and almost 5 times fewer patients suffering a treatment failure. Improving the use of antibiotics in hospitals has the added benefit of actually saving hospitals money. Many studies have documented significant savings after hospitals started programs to improve antibiotic use. Often, the savings run into the hundreds of thousands of dollars per year. The studies I've shown here and many others not only demonstrate the benefits of improving antibiotic use in hospitals, they help show us specific ways to accomplish that task. Consistently, one of the most effective ways to improve antibiotic use in hospitals is to implement a program that is focused on this goal. These programs are called Antibiotic Stewardship Programs. Given the urgent need to improve antibiotic use in hospitals and the proven benefits of antimicrobial stewardship programs in accomplishing this goal, CDC believes that all hospitals should have such programs. We recognize that hospitals vary in size and complexity, and the stewardship programs will reflect these factors and will look different in different hospitals. CDC is working on a variety of resources to help hospitals start and expand antibiotic stewardship programs, including guidance to help define the structure and functional elements of effective antimicrobial stewardship programs, and developing tools that will help hospitals implement and expand programs. For example, in 2012, CDC launched the Antibiotic Use Module of the National Healthcare Safety Network. This module allows hospitals to electronically track antibiotic use, to help them focus on areas of the hospital where use might be too high, and to monitor the effectiveness of their efforts to reduce use. Antibiotic stewardship programs are an important step in improving antibiotic use, but they're only one part of a bigger solution. To achieve the dramatic improvements in antibiotic use that we seek, we need all healthcare providers to become part of efforts to improve antibiotic use. Public health has a vital role to play here. We may not prescribe antibiotics to hospitalized patients, but we can help improve how they are prescribed. One way we can do that is to help shift the very way that we approach the problem of antibiotic misuse in hospitals. For too long, improving hospital antibiotic use has been viewed as the sole responsibility of antibiotic stewardship programs. In order to make the major improvements in antibiotic use that we seek, we need to learn from our model of controlling infections in hospitals. Historically, preventing infections in hospitals was also considered the sole responsibility of the hospital's infection control program. However, these programs have limited staff and hence limited impact. There has recently been a major shift in the way we think about infection prevention in hospitals. We now recognize that preventing infections is a primary job of the clinicians providing care. The infection control program is now responsible for teaching clinicians how to prevent infections and then helping them do it. This change in philosophy has been one of the key factors in the dramatic reductions in healthcare-associated infections of the past several years. We in public health need to highlight this model and urge hospitals to follow it to improve antibiotic use. Public health can play a key role in changing efforts to improve antibiotic use in hospitals. Just as we have done for infection prevention, we can work to raise awareness of the problems posed by antibiotic overuse and the proven solutions to those problems. We can also provide education and training to help hospitals and providers improve antibiotic use. And finally, we can expand efforts to improve antibiotic use by involving new partners. One key group of new partners are hospitalists, physicians who specialize in the treatment of hospitalized patients. They are the fastest growing medical specialty in the United States and already provide more than half of all non-surgical care for hospitalized patients. This means that they probably also prescribe the majority of antibiotics in hospitals, making them an essential partner if we want to expand efforts to improve antibiotic use. Because hospitalists often view quality improvement efforts as part of their core mission, they are an ideal partner for helping us in our efforts to improve antibiotic use. State health departments can also play a key role in our efforts. Our experience with preventing healthcare-associated infections has demonstrated that state and local public health personnel can make significant contributions to improving care in hospitals through awareness, education, and policy. These strategies can also be brought to bear to improve antibiotic use in hospitals. A 2013 survey by the Association of State and Territorial Health Officers reveals that already several state health departments are engaged in educational efforts to improve antibiotic use in hospitals. One state, California, has even passed legislation requiring that hospitals take action to ensure the judicious use of antibiotics, and many other states are evaluating such policies. In summary, I hope I've convinced you that antibiotics are used commonly in hospitals, that antibiotics are often misused in hospitals, and that there are important benefits to improving the use of antibiotics in hospitals, and that public health can play a key role in expanding efforts to improve antibiotic use in hospitals. I'd now like to turn it over to Dr. Sherry Ling from the Center for Medicare and Medicaid Services.
Thank you and good afternoon. So let me begin by saying thank you for including us in this really landmark presentation. And I'm delighted to have the opportunity to talk about CMS programs as mechanisms to promote appropriate antibiotic use. So in the next few minutes, I'll provide an overview of the reasons that antibiotic use and appropriate use of antibiotics is important to the Centers for Medicare and Medicaid Services and to our health system in general, and of course to the beneficiaries that we provide service for. I'll also cover several approaches and strategies that are available to influence antibiotic use. And finally, I make the concluding point of a balanced approach is needed that recognizes the realities of clinical practice and builds on state-of-the-art evidence. So by way of a scope, I remind you that the Centers for Medicare and Medicaid Services are responsible for the care and keeping of roughly 1 in 3 Americans, and that number is actually increasing day to day. And that the Centers for Medicare and Medicaid mission is to pursue 3 aims. That is to deliver better care, that is provide care that is of higher quality, to be able to attain healthier populations, and I think that is where our collaboration can be fruitful in improving the health of the population, and of course the third of which being reducing the quality of care, the quality of cost of care through improvement in quality. So the National Quality Strategy really helps us focus our measurement along the path to achieving the three aims just articulated, that is better care, healthier populations, and lower costs through improvement of quality, but also aligns according to 6 priorities. Those priorities being making care safer by reducing the harm that is caused in the delivery of care. And this likely is the priority that's most closely linked to encouraging appropriate antibiotic use. But just by way of context, we also point out that the priorities include ensuring that each person and family are engaged as partners in their care, in promoting effective communication coordination strategies as patients and families traverse the healthcare system from one provider to another, to promote the most effective prevention and treatment practices for the leading causes of mortality that we've started with cardiovascular disease, and working with communities to promote widespread use of best practices to enable healthy living, and finally, priority of making care more affordable to individuals and families by improving the quality of that care. So there are principles that are implicit in the CMS programs that include that the programs and policies will honor and be built upon a foundation of state-of-the-art evidence. And that evidence can come by way of clinical guidelines, best practices and research findings, and findings from the field through quality improvement. But also CMS welcomes input from and for the selection of measures for implementation, and also constructive measures from the experts, that is, expert guidelines. We certainly have embraced and implemented measures of quality across the care setting in close collaboration with our partners here at CDC and also medical specialties. Importantly, program principles also are built upon a data-driven approach towards improvement in healthcare, towards better outcomes for the patients and families that we serve. We've started with building and implementing measures of quality of care with a focus on healthcare acquired conditions and also of antibiotic use. And what I've depicted here is the landscape of quality reporting, and to my left and to your left is that of hospital quality reporting that has expanded from inpatient and outpatient settings to now include inpatient psychiatric facilities and other types of hospitals, including those that serve patients for high-quality cancer care. Also includes physician quality reporting programs, including physician quality reporting system, meaningful use to encourage adoption and use of health information and technology and e-prescribing, but also post-acute care settings, which include home health agencies, end-stage renal disease facilities, inpatient rehab facilities, long-term care acute hospitals, and also are venturing into the area of population health-based quality reporting with mindful attention to the need to be able to measure at the level of communities and at health plans. I've also highlighted for you that quality reporting is actually the foundation upon which value-based purchasing is being constructed. The first two settings of which have been the Quality Incentive Program for end-stage renal disease facilities and also for acute hospitals that Arjun was just speaking about. But as far as the complete landscape of CMS programs, I just want to highlight a couple. I've already mentioned the quality reporting programs for inpatient and outpatient facilities that mindfully already include measures that address appropriate antibiotic use, either in the context of surgical care improvement practices or more generally. Data and of quality must be available and usable at the site of care and drive towards improvement of quality. So improvement of quality can be implemented through our work with the quality improvement organizations and learning and action and networks that can encourage appropriate use, including discussions and tools to utilize, including antibiotic stewardship programs. And finally, conditions of participation, which describe the minimum standards and expectations for all care facility types, from hospitals to post-acute care settings, ESRD facilities, and all post-acute care settings beyond that, and that the survey and certification program then follows suit and can enforce those conditions of participation through their state surveyor and federal surveyor efforts. We have ventured into value-based purchasing by virtue of the Affordable Care Act. First two efforts include our Quality Incentive Program in end-stage renal disease facilities and also hospitals. But this is simply a tool for CMS to begin to converge quality with payment and quality with costs. Importantly, to drive improvement towards delivering higher value care, not just higher volume care, we must remain fixed on a shared focus of improving outcomes, really engaging all providers and patients in that effort collaboratively. And we have made great strides in this area. Importantly, pertinent to this conversation is that healthcare-associated infections have been included not only in the quality reporting programs, but also in the value-based purchasing construct, whereby hospitals are able to, by attaining or improving on their quality performance, enjoy the higher payments as opposed to lower payments if not to attain or improve in these important areas. We've enjoyed great collaboration and success in reducing healthcare-associated infections. Thank you to our CDC colleagues. Made great strides in reducing catheter-associated bloodstream infections across our country, and are also making great strides in the area of reducing catheter-associated urinary tract infections by consistently measuring, agreeing upon bold goals of reduction, and providing assistance, technical assistance and tools available to enable providers to provide effective care that reduces these events of harm. We've also implemented our quality improvement organizations, our Partnership for Patients effort. This has been a synergistic tour de force focusing on improving and reducing these events of harm on behalf of our beneficiaries and are able to translate that into success. Now, as mentioned earlier, unintended consequences are certainly those that we need to be able to anticipate and preempt, and therefore, although CMS programs are really encouraging early detection and early treatment of infectious processes, of healthcare associated infections, reducing that harm, and where quality reporting then transitions into reporting that is now attached to incentives or payment reductions should you not be able to attain these metrics. There is a concern that the unintended consequence of this will be overuse of antibiotics. And this requires a thoughtful attention and strategic inclusion of measures and efforts that balance this natural tendency towards overuse. That would include pairing antibiotic start measures with those of stop measures. That would include the detection of C. difficile that we heard can result in not only morbidity but death. Monitoring for C. diff and building in measurement quality measures not only within a care setting but across care settings where this condition may manifest as patients traverse from one setting to another. Then, of course, antibiotic stewardship as a consideration as a condition of participation or through surveyor guidance would be one that implicitly provides the balance that is sought. So I would like to conclude by emphasizing that appropriate antibiotic use is an important aspect of achieving care that is safer, of high quality, and of course less costly, and therefore a integral part of achieving the three-part aim that CMS really has marched towards in transforming healthcare. That appropriate antibiotic use by healthcare providers and facilities across all care settings really requires a data-driven approach, data that's available at the site of care, that's actionable for providers, and that can engender and encourage learning on-site and as a system in a way that is fair and balanced. And finally, that through quality improvement systems and measures that CDC and CMS together, along with other partners, are able to work to improve appropriate antibiotic use in hospitals and across all care settings. So I thank you for your attention.
We will now have concluding remarks by Dr. Frieden, followed immediately by Q&A session led by Dr. Hicks.
So thanks very much to speakers for really excellent and informative presentations. The area of how can public health and healthcare work together synergistically is so important to all of us, so important to society, and our partnership with CMS has just been terrific. So we appreciate your being here, and we appreciate the many linkages between the two agencies, which really have grown exponentially in the past few years. Just to highlight a couple of things that might have gone by a little bit quickly, the National Healthcare Safety Network is now active in essentially every hospital in this country, in large part because of the collaboration between CDC and CMS. And as Dr. Srinivasan said, there's now a module that will track antimicrobial use and resistance, and ultimately be able to pull that exclusively from electronic health records, reducing the burden of data collection, increasing completeness, increasing consistency, and speed. Also, with the area of electronic records, we have possibilities of clinical decision support that Dr. Finkelstein mentioned, and we need to explore those and figure out how to make them work effectively. We know that prompts may not always be effective in EHRs because if there are too many of them, doctors turn them off. So how do you meet that balance between what's really important and all those good things that we want to get done? We also heard from Dr. Ling the importance of measuring and the unique opportunity to really change medical practice by better measuring what's happening in practice, both inpatient and outpatient, and then feeding that back in real time to improve the quality of care. We've also heard about antimicrobial stewardship programs and the CDC recommendation that every single hospital in this country have one. We think that'll not only save lives, but also save money. We need to further understand exactly what that means and how to optimize programs like that, and then work with CMS to support hospitals in establishing such programs. And we heard from Dr. Hicks the importance of both clinicians and patients best understanding that more antibiotics doesn't mean better treatment, that more is not always better, that often better is better, and better might well mean watchful waiting for many patients. Ultimately, I think we should think of antibiotics as a gift that's been handed down to us, an inheritance from a generation of doctors going back to Paul Ehrlich and Salvarsan 606 more than 100 years ago, until we had wonderful drugs, miracle drugs that can save lives and are saving lives. But our responsibility is to preserve that resource. Some of them are natural, some of them are man-made, but to preserve that resource so that our children and their children and their children's children can still benefit from this wonderful lifesaver. So thank you so much to all of our speakers.
Okay, so I'd now like to open the floor to questions, and I'd ask you to come to the microphone if you're in the back, and please just state your question briefly. And since I don't see anyone at a microphone, there's a hand raised. Okay, well, I'm going to start off with a question because I have that prerogative as the moderator here, and I'm going to hand this one over to Dr. Jonathan Finkelstein. we talked a little bit about this earlier, but given changes in healthcare delivery, what can we do differently to improve antibiotic use, especially in the outpatient setting?
So I think we've heard a lot of things that point us toward a new future. The development of larger care systems really responsible for populations, whether those are called accountable care organizations or something else, and the payment and quality initiatives that go along with us, with those, really give us new opportunities. We don't have to just keep thinking of campaigns in schools and campaigns in communities. We can work through health systems and really hold them accountable. Say, what's your antibiotic use rate overall across your system? And if it's too high, if it's higher than others who are getting better outcomes, what are you going to do within your context to bring it down? And then, as Dr. Frieden said, I think we can leverage electronic health records and other sources of data to measure more efficiently and feed back to systems more quickly.
Okay, so I see a question in the back of the room, right there.
Yes, thanks. This was wonderful, and actually my question was also about the changes in healthcare delivery, but a little more specifically, I thought it was very interesting that the idea of focusing on hospitalists for all the reasons you mentioned. But I was also wondering more specifically, the mention has been hospitals or outpatient, but what about the blurring of that, the tendency for shorter hospital stays, for outpatient surgical procedures, and has that affected the antibiotic use or misuse rate? And in particular, I guess I want to ask about the question where it's a gray area and the concern for good follow-up is uncertain because maybe this post-op patient is now an outpatient, maybe the mother of the sick child, the doctor isn't so clear about if the child will come back in time if he gets worse. I mean, so this transition, this blurring of the inpatient and outpatient, how has that affected antibiotic use, and what are the issues there?
So I'll just make one comment, and then I'm going to hand it over to Dr. Srinivasan. One thing that comes to mind is the increase in frequency of outpatient parenteral therapy. So there are a lot of patients that are now being discharged on parenteral therapy from hospitals for long-term treatment in the outpatient setting. And so we're definitely seeing a lot more antibiotic use that would have traditionally been used in hospitals in the community. And so there's no question that there is a blurring of the lines between inpatient and outpatient. It's a very fluid situation. And so I think one thing that we say all the time is antibiotic use anywhere is really antibiotic use everywhere, and antibiotic resistance anywhere is antibiotic resistance everywhere. And so we have to kind of think about it in all healthcare segments. We can't just say, okay, well, let's look at hospitals only. This is a widespread problem. So I'm going to hand it over to okay.
Yeah, I'll just echo that. I think that the shift towards groups like accountable care organizations, where the unit of interest and the person is the focus, not the setting. And I think increasingly, that is the solution to this problem. And it's not just with antibiotic use, as Lori's pointing out, relates to antibiotic resistance, it relates to healthcare-associated infections. Increasingly, you have the repercussions of care in one setting being seen in another setting. It's particularly true in long-term care settings, nursing homes. And they're all interconnected. We know that patients get care at a variety of different settings in a given community. So focusing exclusively on one piece of the puzzle is not going to solve the overall problem. We have to take a more holistic approach.
And I would like to add to that. We have a healthcare system. We have an incredible opportunity for us to behave as a system. Now, what is required, and that is part of the beauty of the National Health and Safety Network. It is a network. It's not just a stovepipe data collection vehicle within a single system. It actually acknowledges the fact that people will traverse from one care setting to the next. They'll start in the hospital. They will go, the same people will go then to a home health agency care if they are healthy enough, or to a skilled nursing facility, or perhaps to a long-term care acute hospital, or cycle back to the acute hospital. This is a system that patients are required to navigate and traverse. And I think one of the biggest challenges for us is for our individual providers to start to think about how they fit into the system and how they fit into the team that provides the care to any given patient. It may not be that we expect all providers to do the exact same thing for a measure, for instance. It may be that we expect some providers to start an antibiotic, select it appropriately, start it, but we may expect that care plan and that treatment is continued to another provider. And that is what care coordination is about. That is a fundamental domain within the national quality strategy to improve outcomes, but we must do it as a system.
So I know, Susan, you had a question from social media.
Yes, thank you. From our online audiences, do drug companies consider antibiotic resistance mechanisms associated with the long-time use of their drugs during research and development?
Well, I'd hope so. I actually think that's one of the challenges with antibiotic development is the potential for drug resistance to develop pretty rapidly. And practically for all of the antibiotics we use, we've seen antibiotic resistance develop pretty rapidly for each and every one of those drugs. So I would hope that drug companies that are developing new drugs are taking that into consideration. But on the other end, I'm going to turn it around and say when these drugs are launched, the most important thing is that we're using them appropriately, because if we don't use them appropriately, we lose them. And I think that's what's happened with our current drugs. We really lost a lot of power in the antibiotics that we have. I don't know if anyone else wants to comment on that. Okay. Okay. Am I allowed to have Anne ask one more question?
Do you see another question, Lori?
Yes.
All right, last question.
Yeah, sorry, I didn't know it was over. Lori, I was really struck with your map that showed the differences among states, and particularly that West Virginia had the highest and Alaska the lowest, given that they both have important rural populations and some pretty heavy disadvantaged children. But I remember that back, in the 90s, Alaska actually did some intensive interventions to promote appropriate antibiotic use. In that era, we were really struggling with the ability to take these interventions to scale and to make them sustainable, and wondered about whether you had to redose. So I'm wondering if you have any data to say, why things look better in Alaska, and whether they've been redosing or whether they were always lower and they just, whether you have any insights into that.
So really great question. And I think we're just learning about why we're seeing these geographic differences. One of the first comments I received about that map is that it resembled the Electoral College map, and I've actually received that same email or comment at least a dozen times since that first comment. We haven't looked at the political nature of prescribing, but we have looked at things like obesity, socioeconomic status. We've looked at other health factors and gender, those kinds of things. What we see is there are certain things that do tend to fall out. First of all, we know that in the South, drugs are more commonly used for conditions for which there's no benefit, so we know there's overuse in the South relative to other parts of the country. We also have seen that there's a relationship between obesity, and we don't know how that relationship, whether it's a direct relationship or an indirect relationship, but which direction that relationship is, whether it's chicken or egg. But we see that obesity seems to be associated with high antibiotic use. And then finally, female sex. I think because females tend to use the healthcare system quite a bit more than males, and so if you compare males and females, you'll see a lot more antibiotic use in that population. But I do think we have to better understand why we're seeing these differences, because then we can better figure out how to improve rates in those states with high use.
Thank you again to all of our speakers. Please join us again in 2 weeks for our next special session of Grand Rounds on advanced molecular detection of infectious diseases.